Thank you very much, Philip, for those kind words. I'd like to thank the organizers of the conference for this opportunity to talk about our work in Ghana. And I'd like to join Kwesi to give thanks and praises to Eli Katabiria for the wonderful work he's done in HIV over the years. If we remember in the session just before this, we talked about COVID-19 vaccines. And of course, a lot of the work on surveillance is what has made it possible to understand the need for those vaccines in our setting. So I'm going to tell you about the work we've done in Ghana doing surveillance for COVID-19 using the existing surveillance network for influenza. This project, as you just heard, is funded by the EDCTP. We're very grateful to them for the funding that has enabled us to do this work. So the rationale and objectives of this work are very clear. The worldwide pandemic of SARS-CoV-2 spread rapidly to and within Africa. There was therefore the need for high-quality surveillance data to inform public health responses. We all know that alongside traditional surveillance, most high-income countries utilize modeling and whole genome sequencing as part of surveillance strategies. We've heard today, and we've had extensive data from our colleagues in South Africa about the various variants that they've detected alongside the surveillance clinically. However, we do know that in low middle-income countries, this capacity is less established. Therefore, this funding from the EDCTP enabled Ghana to enhance our COVID-19 surveillance and response system. It was very simple. We set out to expand COVID-19 testing across our existing national influenza surveillance network. We also set out to integrate whole genome sequencing for SARS-CoV-2 into the routine surveillance system. And we also did country-wide specific mathematical modeling, but this data will not be presented at this conference because it's currently undergoing review. Now, the study design was very simple. We have surveillance for influenza-like illness across our country. The map I'm showing you right now shows you the 10 regions of Ghana, which is currently now expanded into 16 regions. So what we did was that we embedded COVID-19 surveillance across 29 sites in 10 regions across Ghana. These sites look out for cases of influenza-like illness weekly and submit respiratory samples from these individuals who meet the case definition to the National Influenza Center at my institute at the University of Ghana. When we receive the samples, we conduct diagnostic testing for PCR by PCR for influenza and SARS-CoV-2. Then we proceeded to establish whole genome sequencing for SARS-CoV-2, and we integrated this into the analysis pipeline. We shared the data directly with the public health authorities and the COVID-19 task force, and this enabled this information to influence and guide our response appropriately. Now I'm showing you a combined scatter plot for influenza and COVID-19 monthly data. I'm very proud of the system that we have in Ghana because we're one of the countries that continue to supply the WHO Global Influenza Surveillance and Response System with data on circulating influenza strains since the start of the pandemic. This is because we managed to maintain our surveillance sites for influenza whilst the pandemic was raging. So throughout 2020 and 2021, we were able to show that we were able to do detection of influenza and SARS-CoV-2 from samples that we received. And we found that during this period, the monthly prevalence of influenza ranged from 0.5% to 25%. And SARS-CoV-2 was 1.7 to about 38%. You know, there were several waves across the period. There were 4 waves across the period, but we have data that covers most of Ghana. And then we set up the sequencing using the Oxford Nanopore Technology Arctic tiled amplicon method. The sequence lineages were typed using the pangolin and phylogenetic analysis using the IQ3 and 3 time method. We're able to show that most of the cases, all the cases of COVID-19 were imported. And we saw this first in travelers, and of course, then it spread to the community. And we detected waves of SARS-CoV-2 infections in Ghana with specific variants dominating across the 4 waves that we experienced in Ghana, just like in other parts of the world. First, there was the B.1, B1.1. Then WHO then came up with the new nomenclature. So we had Alpha, Delta, and then Omicron. And we were able to show the different variants of concern that dominated in different parts of Ghana in different months of the period. And this was really important in helping guide the Ministry of Health, Ghana Health Service, and the National Task Force in the decisions they took with regards to measures for COVID-19. So to conclude, I think that I've shown that continuous genomic surveillance of COVID-19, especially detection of variants of concern, informed interventions with direct communication to the general public. We also show that imported SARS-CoV-2 lineages became dominant in the communities. And influenza has continued to circulate in Ghana alongside COVID-19. And we've adopted a contemporary approach for respiratory pathogen surveillance in addition to influenza. So we revised our national protocols, and now we have a protocol system, a system that looks for respiratory viruses in general, in addition to influenza. So this support from the EDCTP has shown that influenza surveillance systems can be rapidly expanded to become respiratory pathogen surveillance models. Thank you very much.